All right. Well, Fiona, welcome. Thanks for doing this with us. Do you want to just introduce yourself and then we'll dive into the topic?
Sure. Zach, I am your colleague here at Yale University. I teach in the School of Management in the economics area. My research area is called Industrial Organization Economics, and that's the study of firms, markets, and competition. And I've worked on a variety of different industries across my career, but a consistent area of interest of mine has been generic drugs.
Fantastic. So let's talk about the brief, which I think is really cool. Do you want to just outline the topic that you're looking at in your proposal?
Yeah, the topic here is how Medicare and actually all payers pay for physician-administered drugs. Physician-administered drugs are not drugs that you go to the drugstore and buy and bring home in a little bottle of pills. They're instead usually quite expensive drugs that the physician has to administer to you. So you go into the office and you receive an injection, or you sit in a chair and you get an infusion, and so you're not self-administering, but the physician is actually the one purchasing the drug, storing it in his or her office, and then administering it to the patient. And these drugs therefore fall usually under the medical benefit, not the pharmacy benefit, and the doctor is the one buying them.
So let's talk about the problem here. There's a particularly weird way that the Medicare program reimburses these. Do you want to just walk us through the issue in particular?
Yeah, it is weird. The way the Medicare program pays for these is it says, okay, doctor, whatever the market price of these drugs, paid price of these drugs were 6 months ago, we're going to give you that plus 6%. Okay. Now, how do they define what a drug is? Well, that's defined by its J code. So a J code is attached to a particular molecule, and then that price is tracked around, and that's how the physicians are paid. So they're really paid cost plus. Doesn't matter what they individually bought the drug for. They're paid the market average from 6 months ago plus 6%.
So it's, in this space, my understanding is it's really the specialty drugs, the sort of biologics that are small share of the prescriptions, but an enormous share of the total spend. We've seen biologics or biosimilars enter. How does this fit into the reimbursement framework?
Biosimilars are intended to work a bit like generics. Remember that we have a branded drug, it's on the market for some number of years. When its patents expire, a generic can come in, and the generics are usually much, much cheaper than the branded drug. And what happens is everybody switches to the generic, prices fall a lot, and we have a lot of savings. Now, in the case of biosimilars, we're trying to achieve the same thing. The biosimilar is not an identical copy of the molecule, but it's clinically the same. So it goes through a lot of testing so that the FDA is convinced that it's doing the same job. So it's the same medicine. Now, in that circumstance, you might imagine that if the innovator brand and the biosimilar are the same medicine, that maybe they should compete with one another, and that we should have one J code that covers both of them. And then whichever one the doctor picks, the doctor gets the same reimbursement because they're the same medicine. That's not how we do it. We have a different J code for every product. So when the biosimilar enters, suppose it enters at a 30% discount, the doctor has no incentive to buy it at all. Doctor can keep on buying the innovator that's much more expensive and bill the government for that expensive drug, even when there's an inexpensive.
Literally, what would save the government money costs the physician money. So the incentives just aren't aligned. Is that right?
So the physician doesn't have any incentive to dispense the expensive drug. On the other hand, they have no incentive to dispense the inexpensive drug either.
So then, you're proposing changes to how the J codes are structured. Do you want to just go through the changes that you're proposing?
My policy suggestion is that all the biosimilars and the innovator biologic that are the same molecule should have the same J code. And what that would do is it would mean that a physician or a hospital purchasing these drugs would understand that it had one reimbursement, whatever the calculation was, and they would go out and shop for the least expensive of those molecules, because if you're going to get reimbursed $100, it makes a big difference whether you buy a drug that costs 120, 100, 90, or 70. And doctors' offices would, of course, gain financially if they could find a drug to buy for 70. And because the biosimilars compete with each other as well as the innovator molecule, they're going to drive down prices, and we would find drugs available for 70. Now you might say, does that save the government any money? Well, it does, because remember that this benchmark 100 comes from 6 months ago prices. So if everybody starts buying the drug for 70, then 6 months from now, the benchmark will be 70. And so we as taxpayers and buyers of insurance will get lower costs out of this.
So yeah, let's see if we can scale it. What is the total savings that you're estimating? I mean, it's pretty remarkable as a.
Yeah, I think we could get $2 billion easily and maybe more. It depends on how many biosimilars enter, because every time you have an entry of a biosimilar, you open up another market to competition. And if we actually had a J code that stimulated competition, every time a biosimilar entered, you could get these cost savings. And then we know from Europe that biosimilars cause cost declines from 20% all the way up to 70%. So it's quite possible that we get some really significant savings here, which we can't see now because there's no reason for a biosimilar product to cut its price. Why would that attract any physician or hospital to buy from them? There's just no incentive.